Today's episode of Vital Voices is brought to you by Oak Tree Medical Center and Wellspring Lifestyle Group.
Are you enjoying Vital Voices? Do you find our conversations educational, engaging, and inspiring? Then like, subscribe, and tap that notification bell to keep updated on new episodes and more.
Vital Voices.
What if you're always tired or always wired isn't just stress? Today we're unpacking the tiny gland with a big impact, your thyroid. Welcome to Vital Voices, the podcast where we amplify the stories, insights, and expertise of the people shaping the future of our communities, our conversations, and our country. I'm your host, Alexis Burrows. Thank you for joining us. Today we're talking hypothyroidism and hyperthyroidism with endocrinologist Dr. Carmen Cartwright. She's the clinical director of Specialty Clinic at Oak Tree Medical Center. Welcome back to the show. So let's start simple. Let's go to the bare bones basics. In layman's terms, what does the thyroid do for us every day?
Excellent question. So I would say for me as an endocrinologist, the thyroid is one of my favorite glands. It's also, to be truthful, one of our bread and butter diagnoses that we see on a daily basis, if not numerous patients each clinic session. But it's a butterfly-shaped gland that sits here at the base at the front of our neck, just above your collarbone type area, but at the very front base of your neck. And it is the powerhouse of your metabolism. So it helps to drive your metabolism, supporting, brain function, heart function, muscle function. It exudes its effects throughout the body entirely. So it's, the main driver of your metabolism.
And then explain for our listeners metabolism, what that means in terms of just everyday.
Understood in terms of layman terms again. So that's helping you to maintain adequate energy levels for your body to function, in terms of ensuring that you have adequate metabolic rate. Even itself doesn't sound layman's terms enough, but it's in terms of ensuring that your body has what it needs, what is brought in from a nutrition standpoint, to allow it to then shunt the energy where it needs to be, so that your body can be fueled as it should be to support the tissues and the functions that need to take place.
I gotcha. So it's like the conversion of your food intake into energy in the body. In a sense
of especially directing that energy, because obviously insulin is going to be the big driver, at least from a glucose standpoint, but it is the main driver of keeping our bodies going.
Okay. So what is, I think for anybody who's probably familiar with thyroid has probably heard hyper and hypothyroidism, which is, underactive and overactive thyroid. What is the simple difference between those? Like if it's overactive or underactive?
Excellent question. So you kind of hit the nail on the head that that's exactly what it is. So euthyroid is a term that we could become familiar with. It means that you are having adequate thyroid function to maintain your bodily functions, metabolic rate, ensuring that things are being supported as they should be. But hypothyroidism is underactive thyroid. Your thyroid is not making enough of that hormone to send those signals and those messages to keep things going. So I tell patients, think hypo, O for low, hyper, think higher for overactive thyroid. And it can lead to significant derangements and issues throughout the body if we are one direction or the other.
How common are thyroid problems? I can think of one or two family members with varying degrees of distance who I know who have had some issues here or there with their thyroid. But how common is it, and I guess who's most likely to have challenges with their thyroid?
Excellent question. So I would say the prevalence, unfortunately, there's not always the best amount of data for us in the Caribbean. So we have to look at the United States or worldwide data. Hypothyroidism, so low and underactive thyroid, is actually the more common entity, and that's about 2% worldwide. If you look at American Thyroid Association, just general information for patients, they say about 12% of the US population at some point in their lifetime will have a thyroid disorder of some sort. Recently, FDA was putting out a statement in regards to one of the thyroid replacement options and where they're going with that. But they had stated that in 2024, 22 million U.S. citizens were prescribed thyroid hormone replacement. So that puts it into perspective how many people are dealing with underactive hypothyroidism. Hyperthyroidism is about 1.5%. So it's lesser compared to hypo, but it is still very prevalent. And unfortunately, as with a lot of autoimmune diseases, it's far more common in women. So about 5 to 8 times more women will suffer from underactive thyroid compared to men. And smokers are actually more likely to be at risk for overactivity of the thyroid. Not that that automatically equates, but it's something that has been seen to be associated with overactive thyroid.
Okay. So I think, obviously when we do the show, one of the things we want to be able to give people is some advice and guidance on what to look out for, right? So basically it's like, what should we notice in real life? That's I think the big question overall. So for underactive thyroid, what are everyday signs that should raise an eyebrow for someone to say, I wonder if I need to go and get this checked out? Sure.
So with underactive hypothyroidism, your metabolic rate is being set down because you do not have adequate hormone. So everything shifts down, everything becomes slower. So digestion slows, people can become constipated. They feel cold easily. Everyone in the room seems fine, but they're grabbing a sweater or grabbing a jacket. They feel easily tired. They have issues with hair thinning, dry skin. For women, menstrual irregularities. But to be truthful with you, it's not that if your cycle behaves a particular way, is it telling me more likely under or overactive? So I would just say menstrual irregularities in general. You're skipping periods, longer periods, bleeding heavier than you've ever known normal for yourself. We think about the womb as a possibility, but even thyroid dysfunction could lead to issues in that way. A lot of patients for hypothyroidism complain about brain fog, but that's a very difficult thing to measure. Obviously, that's more so in terms of subjective feelings. Weight gain is a big one, especially if you're finding, I'll notice for patients and I'll think about it, even if it's not necessarily weight gain. If let's say it's that they're trying to lose weight, they're making all the lifestyle efforts and they're having trouble dropping the weight. I said, well, maybe it's your thyroid. It's not always, but it could be. Other than that, for the underactivity, they are more likely to suffer from muscle pains in that they can have easier muscle breakdown. And from a standpoint other than symptoms, also when patients go to have like their general blood work, if their cholesterol is out of control, especially the bad cholesterol, the thyroid is also helpful in keeping that under control. From a hyperthyroidism standpoint, again, we're setting the metabolic rate higher, so things are ramped up. So patients can feel their heart racing, heart skipping a beat. They can have difficulty with unintentional weight loss, which can be really distressing for patients. I had a patient in the past who dropped, 30 pounds in the space of 2 months and wasn't trying to lose weight and was already a petite person. So again, it was very troubling to them because obviously things that come to your mind, thyroid, but also cancer comes to mind, sure, right? So weight loss, feeling your heart race, easily getting hot. Everyone in the room seems fine, but you're breaking out into a sweat. You can't get cool. Diarrhea, but sometimes it's not necessarily diarrhea. It might just be a more frequent bowel movement that was ever normal for you. So, that's something for us to think about. Tremors or anxiety. So patients, when they're having that elevated... Exactly. When everything is up, they can have like a little bit of a shake just to their fingertips. They can have issues with sleep because they're feeling anxious and on edge. And those are the biggest symptoms. And again, menstrual irregularities for ladies. But as I mentioned before, that could be either direction.
That one could go either way. I guess there's a number of things that come into play with that particular issue. So I think the big question then would be, is there anything on either side, whether it's for hyper or hypo, where if you experience this symptom, it's kind of like a drop everything and go to the doctor, whether it's urgent care, emergency room? Like, is there anything that kind of stands out like that?
I think it's harder for hypothyroidism, for underactivity, because if you think about it, fatigue, difficulty with weight loss or weight gain, and just, depressed mood, I apologize, I forgot to mention for hypothyroidism, could be attributed to so many other things. So I think it's harder in that way. However, if underactive thyroid is gone unnoticed for a very long period of time, people can get to a point where they can have a significant change in their mental cognition. Like they can become very hard to arouse. They can also they can be very drowsy. Their heart rate can drop very low. Their body temperature can drop very low. And that would be an instance if you saw, a family member confused or not behaving as they should be. It's something to consider. Obviously, stroke is a possibility too if something of that nature was happening. But I think from a hypothyroidism standpoint, people can exist with hypothyroidism for a much longer period of time and not get to a point where it's just, stark in their face, go to the emergency room. Whereas the overactive, is more of an instance where somebody could end up in a situation. So let's say if you have recurrent severe feelings of your heart racing and beating out of your chest, skipping beats to the point that it's causing you to not be able to feel that you can get a good breath in, right? Or you start to have issues with high body temperatures, because again, that can be at the far extreme. People can start to have abdominal upset with nausea and vomiting. Again, we can suspect that could be caused by so many reasons. But if there's any possibility of a thyroid disorder, that would be an instance to say, I need to get checked. That may not necessarily have to be the emergency room. It could be in urgent care, for instance. But I would say if they were to the point of significant elevated heart rate or feeling their heart race to the point that they can't get it to even calm when they're sitting down resting, that should, push them for prompt evaluation.
Yeah. Okay, fair enough. And then I guess, you mentioned obviously that both hyper and hypo can have impacts on the menstrual cycle. And so that's kind of a part of my next question. Do the symptoms look different depending on if you are a kid versus an adult versus like a woman who's just had a baby?
Excellent thought to have and to wonder. So I would say for kids it can be different, and I will actually say I'll ask for forgiveness of the pediatricians if anyone's listening. As an adult endocrinologist, I don't see kids, right? So I had a very limited amount of training in my fellowship, but still we read and we understand. So with kids, underactivity will be more likely to lead to issues with poor feeding, poor muscle tone. They could have like lackluster energy, things of that nature. Weight gain obviously is another thing that can still come to mind. It can also be developmental delays in terms of their cognition, because again, your brain depends quite a lot on thyroid hormone as well. Whereas with hyperthyroidism in kids, it could be irritability. It might be hard for them to express that their heart is racing or skipping a beat, but they're just irritable, or they're having issues with weight loss, or you actually see them having a bit of a tremor, or their fingertips shaking, or they're like breaking out into a sweat where everyone's fine in the room. During adult life, most of the symptoms I spoke about before, it could be either direction. And you'd be surprised. I've had patients walking around, with severely underactive thyroid, and they're just living their lives, right? They're not really perturbed by it or bothered by it. And they have, drastically off labs versus someone who only has a slight change and they can feel it very differently, that they've noticed something is different about their body. So the labs can be sometimes representative of how the patient feels, but sometimes it doesn't always equate. In terms of elderly population, so in our older community members, you can actually have something called apathetic hyperthyroidism, where, again, with hyperthyroidism, everything's high, shaky, anxious, weight loss, heart racing, hot, and heat intolerance, diarrhea, and so on. In that instance, they will actually have a big predominance of fatigue, which is more so a low symptom. They could have a lot of apathy, where they're just not caring for their surroundings, almost like they're depressed, right? And then the biggest symptom that will actually bring them to be seen is weight loss and heart failure symptoms. Because what happens with prolonged, long-term overactive thyroid, if your heart is constantly beating fast because your metabolic rate is up, it will tire your heart over time. It will put a stress on the heart over time. So those are the biggest things you'll see. And then you'd ask also pregnancy or postpartum. Postpartum. With postpartum, it can be difficult in that if you have postpartum thyroiditis, which is most commonly what we'll see, thyroiditis meaning inflammation and release of thyroid hormone from the gland, they will have symptoms of the overactivity. However, within a couple of months, they can tip right down, way down into underactivity. And then they'll finally come back to normal. Exactly, they'll balance back out. So I would say usually for postpartum, it's going to look like your run-of-the-mill hyper, but it could, beg your pardon, look like hypothyroidism depending on where you catch them in the curve and the duration of the disease postpartum.
Yeah. So it's just something where it seems like if you're having those sorts of issues in post pregnancy, then it's just good to just get. I guess this is why they have those regular checkups scheduled for women after they have kids, because it's like there's all kind of things that are in play.
Correct. The reason, a big part of it too, is a lot of thyroid disease is driven by autoimmune disease. The major cause for underactive thyroid or hypothyroidism is Hashimoto's, and that's an autoimmune disease, at least in Western society where we don't have iodine deficiency. Hyperthyroidism, one of the most common causes, apart from little growths and nodules in the thyroid that can misbehave, is Graves' disease, which is also an autoimmune disease. And a lot of times in postpartum, if you think about it, when a woman's holding a pregnancy, your immune system actually gets pretty docile. It kind of sits small and, hey, don't do big things because we don't want to reject the baby. And then right after, your immune system's like, hey, I can come back full force and be myself again. And sometimes autoimmune diseases can come out that way. So that's why postpartum issues, like for instance, people who deal with, lupus and different disorders, Crohn's disease and autoimmune, maybe unrecognized thyroid disease, then comes out postpartum.
So, I think as with anything in this space, the next big question people have is, okay, so how do we figure out what it is, right? Because I think that's where sometimes a lot of the fear comes in, is like, well, what is the diagnostic process? Like, how do you test? What do you do? What is the testing modality? If you have someone in front of you and they're having symptoms, how do you go about determining, is this actually hyper or hypothyroidism?
Excellent question. So I would say, as with anything we do in medicine, we have to have a clinical suspicion first. So based on the symptoms, if someone sits in front of me and says, oh my gosh, doc, my energy level is down, I'm cold all the time, I can't drop this weight, and now my periods are just, not behaving as they did before, I'm going to be considering hypothyroidism. Versus if someone comes to sit in front of me and they've dropped, 20 pounds, but they weren't trying to. They feeling their heart skipping a beat. I can visibly see them having a little shake in their fingertips while we're talking. I'm thinking about hyperthyroidism. But the initial blood work involves three major things. It is your T4 level. Free T4 is usually preferred. A total T3. And those two are actually the level of the hormone coming from the gland. So you have thyroxine, which is T4, and you have triiodothyronine, which is T3. And then we also check TSH. TSH is thyroid stimulating hormone. It is what is secreted and released in your bloodstream from the big boss pituitary gland in the brain that tells the thyroid what to do. When we then assess all of those three pieces together, it helps us to have an idea. Does it fit with what our clinical suspicion were, or what it was, beg your pardon?
Okay. And so what about antibody tests? Because I know I was doing some research before we did the episode, and I saw that that's a potential option for this as well.
Most definitely. So I more so use antibody testing in patients with overactivity, and we're trying to discern what is the reason. Because again, I'd mentioned earlier, Graves' disease is a big reason for hyperthyroidism. Antibody testing helps us to know, do we see that? So you would test things such as thyrotropin receptor antibody, or TRAb. We would check thyroid stimulated immunoglobulin, TSI, and those more often will be associated with hyperthyroidism. I would use that especially a lot in patients because there are some limitations for us here at home. We don't have radioactive iodine uptake and scan here in country. We used to have it years in the past, but I think there was probably an issue with storing the nuclear reagent. Not that it was harming anyone, just it would go bad before it would be used. So I think that's part of it, but I digress. If someone, let's say, has multiple growths within their thyroid, and now I'm trying to answer the question, is it one of these growths that's misbehaving, or is it the whole gland that's misbehaving? Now, for hypothyroidism, you could do thyroid peroxidase antibody, which is TPO antibody, or you could do thyroglobulin antibody. To be honest with you, I don't have to have those lab results if clinically I have no other reason to explain or any other concerns, beg your pardon, of why they could have underactive thyroid. So people can have underactive thyroid because of Hashimoto's, which those antibody tests would come back positive, right? Versus, let's say someone had an overactive thyroid in the past, we treated it, and now they're underactive. Or they had issues in regards to a pituitary concern. They had to have pituitary surgery, so now there's no signal going to the thyroid telling it what to do anymore. If there's something in their history that clues me in that there's another reason, or rather still nothing else to suggest another reason, Hashimoto's is the most common cause in our society. Versus if you had the situation of, other countries where there's iodine deficiency that's really rampant, goiters are very common, and those patients are high risk for underactivity. So I won't necessarily order antibody testing on every single hypothyroidism patient. I ordered far more on my overactive patients because it helps to understand where is it really coming from. Right.
That's what it sounds like, is that the antibody testing goes into the space of figuring out what exactly is the mechanism behind it.
Right. I mean, there is one other instance, I apologize, where the antibodies can help is in pregnancy. So TPO antibodies and TG antibodies, thyroglobulin antibodies, these are, and to clarify what antibodies are, I apologize, we're throwing this word out there. Not everybody may know what antibodies are. So let's say you're walking down the street, someone coughs, and you get exposed to the droplets that they coughed. Antibodies are the warriors to protect your body. They usually will target things that don't belong, but they can sometimes target things that do belong. And in autoimmune diseases like Hashimoto's or Graves' disease, they are targeting the thyroid and either pushing it down and destroying it over time, which is Hashimoto's, stopping it from working, or they are stimulating the thyroid to be an overactive powerhouse, almost like a bodybuilder, to make more. But in overactivity and hyperthyroidism, knowing the antibody levels can help me to understand several things. In pregnancy, what is the likelihood of them affecting the baby? Because they can actually increase the risk for overactive thyroid in a fetus. They also help me to know, is the patient going into remission? So it helps for hyperthyroidism. Oftentimes, once patients have hypothyroidism because of Hashimoto's, it's unlikely to go into remission. It's usually something that's happened. The gland has been destroyed and it's not going to come back. So we don't usually trend those, but that's another way that those antibodies can help.
Okay, fair enough. Is there imaging involved in this? I know you mentioned you don't typically have the iodine deficiency issue here, but is there any other types of imaging, ultrasound scans that come into play with the diagnostics for this?
So thyroid ultrasound would come into play, especially in situations of overactivity, because again, we're trying to ensure, is it the whole gland misbehaving? Is it just a growth within the gland? And the thyroid ultrasound won't necessarily answer that by itself. I have to use that along with the antibody testing. Radioactive iodine would be the best because it helps you to see if one little spot is lighting up as opposed to the whole gland. But here locally, we use the thyroid ultrasound because if, let's say, you have overactivity, your antibody tests are negative, and I see nodules, then I say, okay, probably one of those nodules is misbehaving. And at that point, I might ask you, are you willing to travel to Florida to have that test done? Right. Whereas if your antibodies are positive, even if you have nodules, I'll say, well, it's probably still your whole gland because nodules will not cause you to have positive antibody tests. So thyroid ultrasounds can also be used if, let's say, someone comes and they have a very large thyroid, and that's how actually the whole ball started rolling for them to be assessed. I had a patient just like that last week. Said, oh, my family member noticed that my neck looked bigger than normal, and I went and I got a check, and thyroid ultrasound was done, thyroid function tests were done. So sometimes we'll do it just to assess the fact that we see it enlarged. Sometimes if on exam we actually feel a nodule with our fingers, which not for many patients will it be that case. They can sit further back in the gland and you can actually feel it with your fingers. But thyroid ultrasound, yes, in some cases, and most often in overactivity. Sometimes we'll even consider, depending on how large the gland is, if a patient is to the point where it's starting to impact their breathing because your windpipe sits right behind your thyroid. Your esophagus, which is the mouth, the tube, beg your pardon, that connects your mouth to your stomach, sits right behind your thyroid. So if, let's say, it's getting very large, sometimes a CT scan can be done to see how far has it really impacted your windpipe, because that might be a reason to go for surgery. Even if your thyroid's functioning fine, we might say take it out.
Yeah, actually, might have too much thing, whatever the growth is. Yeah, okay, that makes sense, because that then becomes more of a physical, mechanical issue than
Exactly.
a hormone
Functional issue.
Right.
Exactly.
Gotcha.
Yep.
We live in a time where people are taking all kind of different vitamins and supplements and things like that. One of the things that I came across was, is there a possibility of, even just common medications that people are on that can throw off the lab work, the testing?
Sure. Yes, there definitely is. So a big one I usually will discuss with patients before doing thyroid function tests, or let's say if they've already come to me and they've had them done and they're only a little bit off and they don't fit clinically, and I'm like, you know what, I don't know if I really trust these labs. I'll say, what do you take? Supplements. I'm like, bush medicine, anything. Tell me everything, right? And biotin is a big one. So biotin can be in your regular multivitamin. It's very often in B complex, in hair, skin, and nail vitamins. You see all the pink bottles on the shelf. And I'll usually pull it up on Google and see what the contents is. Because if it's less than 100% of recommended daily value, it is unlikely to interfere with the tests. If it is a significant amount, then patients can end up where it can lead us to not trusting those results. So I'll usually have patients hold it for at least 5 days before the lab work. It doesn't hurt your thyroid. So I don't want people out there who are taking biotin to be worried that it's actually hurting your thyroid. It's not. And thankfully, B vitamins or water-soluble vitamins, you will just pee out the difference. So even if your body doesn't need it. But it can interfere with the accuracy of the test.
Right. And that's more so the issue is you want to get the results of your testing, right? Okay.
There are a couple other things just to let you know. Estrogen. So if anybody's on birth control tablets when you go to check your thyroid, as long as we as physicians are ordering free T4, that's important because it affects the protein, which is like a shuttle bus to take thyroid hormone around, and it can make it appear higher than it truly is, and it's just a consequence of more protein being there. And then there are common medications that can actually interfere with the function of the thyroid, whereas those two that I mentioned more so just interfere with the tests rather than true function.
So, we also now live in a time where there are millions of stories, right? And people will say, well, my symptoms look like this, but my labs look like that, and it doesn't look the same. So in the case if you're sitting down with a patient and clinically they appear to be being affected in some way in terms of whether it's hyper or hypo, but the labs don't match up, what usually is the next step in the process? And I know people probably get scared of that too. It's just like, if this doesn't look like it's making sense, then I want to know, like, what can I expect?
Happening?
Right. What can I expect to happen next?
Understood. So the questions that would then come to my mind is, how well do I trust those thyroid tests? That's the first question I always come about with. The second would then be is that if they really are not matching the symptoms that the patient is having, one, I validate their symptoms because nobody wants to feel unheard, right? Everyone, even me when I'm a patient. And then we have to delve into the fact that a lot of these symptoms can exist in other disease states, right? Fatigue could be for B12 deficiency. It could be with severe vitamin D deficiency, lack of adequate sleep, uncontrolled sleep apnea, anemia, which could also cause cold intolerance, which is that feeling where you're cold but everyone else is fine. So then we talk about, and I'll discuss with the patient, could there be something else that's leading to it if I trust the tests? Right. And sometimes even if I trust the test, if the patient, let's say, has a strong family history of thyroid disease, or a strong family history of autoimmune disease, because sometimes they will be the first one in their family, but they have, a family member with vitiligo, or they have a family member with celiac disease or type 1 diabetes. Their risk of having an autoimmune thyroid disease is higher than the average person, depending on how close that family member is to them. I might sometimes say, you know what, we could check this again in a couple of months. Let's check it and let's see, so you can have that validation. The other thing would be is if there was any recent illness, belly bug, common cold, that can also disrupt the thyroid function naturally. So if it doesn't fit, I'll tell the patients, if this was, that illness happened within 8 weeks of that blood work, I wait at least 2 months from the time that illness happened and I recheck the labs so that they can get some sort of an answer.
So in some instances, you just have to give it time and try again, try the testing again. Okay. So, we've walked through the basics, we've walked through diagnostics. What does treatment look like? So, you've had a patient come in front of you, you've diagnosed them with, and we could do this separately, hypo and then hyper. What is the treatment plan, the day-to-day management look like? And then what is the turnaround time in terms of how quickly they can expect to feel better?
Understood. So let's do hypothyroidism first then. So underactive thyroid. So the initial step would be to start them on thyroid hormone replacement, which is thyroxine, levothyroxine. So thyroxine, what we normally produce in our bodies. Levothyroxine is synthetic man-made thyroid hormone. Synthroid is the big brand name that most people will know here locally. And we start replacement. It's important that patients are counseled how to properly take the medication. So when it was studied first thing in the morning, empty stomach. I tell patients, yes, it needs to be on an empty stomach, but it doesn't have to be first thing in the morning. It needs to be at a time you're going to be able to remember it, right? Because I've had patients before who'll come back and their thyroid looks like it's not properly replaced, but then they say, oh, doc, actually, you know what? About 4 or 5 times out the week, I miss this medicine because I forget, or I don't have it where it's easily accessible. But either way, we start thyroid hormone replacement, and the dose we give is dependent on several things. It's dependent on your size in terms of your body weight, and it's also dependent on your age. Reason being, for instance, if I chose a patient like yourself, a younger gentleman, right? I'm going to give you more replacement because I'm not as concerned that I'm going to make you have overactivity and putting a strain on your heart. Versus if I have, a 75-year-old or 80-year-old patient who already has atrial fibrillation, which is an abnormally high heart rate, abnormal rhythm, I can make that worse. So then I start slower. I go lower, beg your pardon, and slow for the dose adjustments for them. In terms of the time frame to see a real change, I would anticipate at least 4 weeks. For hypothyroidism. Reason being, it takes that amount of time to reach a steady state of thyroid hormone replacement. I also counsel patients, apart from it being on an empty stomach, they have to avoid combinations or taking it with certain other supplements and medicines and so on. Antacid medicines are a big one. They can block the absorption. Anything with calcium, zinc, iron, magnesium, which commonly exists in your multivitamins, they should be spaced at least 4 hours apart. So I'm not saying you can't take those things, but they can block how well your belly absorbs the medicine. And that's really important for you to know. So usually once a patient starts the medication, in about 6 to 8 weeks, we'll recheck the level, see where they're at. I like to use the Goldilocks analogy in that we got to find the right dose for you. Not too hot, not too cold, just right. Because everyone is different in what they require. So that's hypothyroidism. For hyperthyroidism, our main goal is to get the excess thyroid hormone down fast, because the excess thyroid hormone is, again, putting you not only at risk for the symptoms that make you feel not so great, but at risk for making your bones weak before their time. I apologize, that's something I forgot to say earlier on in terms of it can make your bones weaker, put you at higher risk for osteoporosis. And obviously putting you at risk for abnormal heart rhythms, which puts a strain on your heart. So we usually use medications like methimazole, carbimazole, or PTU, propylthiouracil, are the ones that we use. Methimazole is the one I use most commonly just because that's what I trained with. It's easily available. Depending on the dose, we may dose it more than once a day, which is unfortunate. Who wants to take a medicine more than once a day? Exactly, nobody.
They don't want to take it once a day.
And then depending on the severity of their symptoms and their heart rate. So let's say that they're having significant palpitations, feeling their heart skipping a beat or racing. I will also give them a medication to help to reduce their heart rate and to take the edge off of the shaking and the anxiety, which are medicines like propranolol, atenolol, metoprolol. So that adjunct, that's an additional medicine that isn't really affecting the thyroid, just helping to dull the symptoms, will work way faster. So that's going to be days. The methimazole itself also will work to start reducing the thyroid hormone in days. But it's the same thing. I'm going to wait 6 to 8 weeks before I'm going to recheck the labs. Unless someone is so high that I just want to make sure it's coming down, I might do it a bit sooner than that.
Because I guess if it's dangerously high, then you want to make sure you're keeping close eye on it. Okay. I think another question that naturally comes up when you start to talk about like medication, what are some of the side effects and things like that people may need to be worried about depending on whether they're taking medication for either hypo or hyperthyroidism?
Awesome question. I get it all the time, especially for the hypothyroidism patients who are going to be on this medication possibly lifelong. As long as they're not in postpartum thyroiditis where they're in that phase where they might come back to normal. Most patients, once I start them on synthroid or levothyroxine, it's going to be for life. So people get nervous when they hear that. Thankfully, with levothyroxine, I tell people there's only two big things that could happen. One, some of the manufacturers make different color tablets for different doses, and sometimes people have allergic reactions to the inactive ingredients. So I told them that's not a problem. If that happens, we put you on the brand that does not come in different colors. The other would be is if we don't give you the right dose. So if the dose is too much, you're going to feel like someone who has an overactive thyroid. Or if the dose is too little, you could feel you feel like under-replaced in terms of fatigue and tired and muscle aches. Exactly. So that's the big things with synthroid or levothyroxine. With methimazole, it is at doses above a certain level. So at doses greater than 30 milligrams per day, you have high risk for liver injury and also for reducing your fighter blood cells. So I usually, fighter white blood cells for bacterial infections specifically. So I usually counsel patients, if I'm going to have them on high doses, I say, look, if the right upper part of your belly starts to hurt, you start feeling nauseous, you're pushing food away, you start getting really pale stools, dark urine, whites of your eyes turning yellow, you need to call me. That isn't I'm going to wait until my 3-month appointment. No, you call me. Exactly. Or if you have a fever or sore throat that isn't going away and you can't explain it, we need to check your fighter blood cells. But thankfully, on lower doses, that risk goes down. The reason we don't use propylthiouracil uracil or PTU that often is that one's actually worse in that it can actually put people into full-blown liver irritation close to liver failure. So we use that very sparingly, usually in the first trimester of pregnancy because it has a lesser likelihood of causing birth defects. Not that it's not a risk still, but overactive, uncontrolled hyperthyroidism is a risk to the baby too. So we, weigh the benefit and the risk.
Boy, pregnancy is 1 foot here and 1 foot in the grave, so it's kind of like...
Sometimes that's how it could feel, depending on what you're going through. It is...
Yeah, because you have so many issues. Like, we've had a couple of different conversations on the podcast, and pregnancy it's getting through it unscathed is a miracle unto itself because of so many of the things that can happen while we're pregnant.
Correct.
Your body's just at so much risk. So let's start to think about special circumstances, because I think a lot of what we've talked through so far is, run of the mill, you come in, you get your testing, you put on medication, you monitor it, so on and so forth. Mm-hmm. I think we talked sufficiently through how that looks in the pregnancy space. I guess in terms of if you're trying to conceive though,
yes,
and you come into having a diagnosis, how does that look?
That is a very good point, in that undiagnosed and uncorrected thyroid disease, apart from the menstrual irregularities, therein could also affect your fertility, right? I have a run-in joke with my patients that if they're seeing me for thyroid dysfunction and they're of conceiving age, we have a conversation from the bat. Are you wanting to get pregnant right now? I need to know what the plan is, because if this is something you want, 6 months from now, we need to move things along and make sure that you are where you need to be. Reason being, and my joke, I apologize with patients, is you find out you're pregnant, you call your partner, you laugh or you cry, however you feel about it, and then you call me, because immediately your medicine needs to change. The dose, even if it's synthroid or levothyroxine for underactivity, has to increase. Baby's brain development largely relies on mom's thyroid. So if it is not appropriately replaced, baby's not going to do great. Uncontrolled hypothyroidism, underactive thyroid, also puts women at risk for preterm labor, miscarriage and pregnancy loss. So it's important for the thyroid to be adequately controlled and quiet to get pregnant and have a safe pregnancy. That is not to scare the ladies out there that if you have a thyroid disorder that you're not going to be able to have a smooth pregnancy. You can, but it just takes a little extra work. in that we have to be very cognizant and aware and keeping a very close tab on how the thyroid's behaving.
Mm-hmm.
Yep.
You mentioned in pieces here and there, nodules, goiters, things like that. And obviously when people hear nodules, they think cancer. That's the natural, right? That's the natural correlation. So if you find nodules or you have a patient who has goiters, things like that, how do you investigate that? Like when you go into, like, do you decide if you need to biopsy? Like, how does that change the dynamic when you start to see those physical issues?
Depends on what we find. So let's say if it is a large goiter, and a goiter is just another term for an enlarged thyroid gland. So let's say someone comes to my office and they have literally what looks like a softball sitting at the front of their neck, but they have no thyroid issue with the function. And that can happen. Size and function don't equate with the thyroid. I know, it's great. That baffles your mind, right? You're like, oh gosh, this must be like a bodybuilder making so much. No, it can actually oftentimes be the opposite, in that people with hypothyroidism can be at a greater risk for goiter. In any event, if someone has a goiter, depending on their thyroid function, then designates what we're going to do. So like, let's say they have a thyroid goiter, but the function is fine. They currently have no specific nodules, but the whole gland is just large. We'll just watch it. If you start having compressive symptoms, though, where you have trouble breathing, especially when you lay flat at night, you have trouble swallowing, you're starting to see changes in your voice because the nerves that control your vocal cords run across the thyroid. And if it gets too large, it can start to disrupt those nerves. Then we might send you to our ear, nose, and throat specialist, colleagues, say, hey, let's take out the thyroid. In terms of nodules, we have risk stratifications. So depending on how it looks, depending on the size, both thyroid specialists like myself and my colleagues and radiologists have different categories to say, okay, if it looks like this, what is the risk of it having cancer? And then that helps us to guide patients to say, okay, is this just something we're going to watch in about a year with another ultrasound, or do we need to biopsy it now? And thankfully, thyroid biopsies are not to be feared. So if anyone out there is, has been told that it needs to happen, thankfully, we use needles that are actually smaller than what we use for blood draws in terms of, the girth of it.
Why are you saying that automatically means it hurts less?
It'll be different. They numb the area.
Right.
I do counsel patients that you could still feel the tug and the pressure, but you shouldn't feel the sharpness, you shouldn't feel the pinch.
Right.
And to help you feel even more reassured, they use ultrasound to show them where the needle is going. They don't have to go past your windpipe or through it, right? They don't have to go through your esophagus or anything like that.
Because of the location of it, there's
People
lot of
get nervous.
Anxiety that you get about just where it is on the body. Right.
Correct. But we use an ultrasound to help us see exactly where we're going. So thyroid nodules are very common. Mm-hmm. And truthfully, as people have more and more images for different reasons, we often find them incidentally. We'll be like, oh, you had a chest CT for a different reason. Mm-hmm. Oh, by the way, you have a thyroid nodule. Right. But ultrasound is the best way to characterize them and to follow them over time.
I got you. So, let's transition. Prevention might not be the right word. Risk reduction might be a better phrase. But what are, and then I guess even just in terms of as a part of the management process as well, what are some practical lifestyle habits that actually help in terms of whether you're looking at risk reduction or you're looking at in the ongoing management of a thyroid issue?
I get a lot of questions about, is there anything I need to do supplement-wise, diet-wise, lifestyle-wise? So I would say from a diet standpoint, it's to ensure that you are not lacking in iodine. I'm not recommending that you go out and start taking an iodine supplement, although it is a part of a regular multivitamin. You do need adequate iodine, especially when you're pregnant. So prenatal vitamins have a bit more. And the reason being, iodine deficiency can put you at risk for a large goiter, can put you at risk for your gland growing larger and larger over time because it's having to work harder to try and make thyroid hormone. It uses iodine. There's some data in regards to selenium helping specifically with thyroid eye disease in people who have overactive thyroid. So selenium can be something that, can be helpful. And I think from natural sources, I think mushrooms is one of the big places that you can find selenium, and Brazil nuts, beg your pardon, is another one. So if you don't necessarily want to take a supplement, those are things that you can incorporate into your diet. Yeah, and I would say cigarette smoking can worsen thyroid eye disease. So if you are someone dealing with that, I would say don't smoke, right? Give that up.
I think that's just the general bit of advice is don't smoke.
Yeah, of course, right? It keeps going back to that. No, for sure. There used to be some question years and years ago, and a lot of medicine becomes trial and error. We do studies to see if what we are doing is correct, what evidence is showing us. So it used to be in the past, let's say that someone came to see an endocrinologist and they had a thyroid nodule, but their thyroid was functioning fine. They would actually give you thyroid hormone to try and suppress the growth of the nodule. And then they found that wasn't working. So we stopped doing that. And we were actually causing people issues. Right. And that obviously they would become hyperthyroid depending on how much you gave them. Right. So we were causing more harm than good. So we don't do that anymore. There are, from a lifestyle standpoint, there isn't much else to think of that I can pinpoint at this moment in time.
Okay. Obviously, I think one of the other questions that people will have is, so what does life look like long term if I am diagnosed with hyper or hypothyroidism? I think you mentioned with hypo, the expectation is essentially you'll be on medication for the remainder of your life. And then I guess what are some things that people can do to kind of just, I guess, live with it without feeling like it's overwhelming? Because I think that's the thing too. When people get diagnoses, a lot of times the concern is like, it's this, oh my God, I'm dealing with this for the rest of my life. But, what does that process look like? Like, even once you get stabilized, how often are you doing labs? What does your follow-up look like? Right. Just what does that whole process look like post, being diagnosed and starting a treatment plan?
Okay, so for hypothyroidism, as you correctly reiterated what I said earlier, for most patients is going to be lifelong. Obviously, if you had your thyroid removed for a reason, right, the factory's gone. You got to have the replacement. Or if Hashimoto's, that autoimmune disease, has destroyed it, you're going to need it lifelong. For most patients, once you find the right dose, usually we can go, in the first year of getting to stability, every 6 months. Once you're good, that's once a year in terms of checking the level. But I would say it is important to remain adherent and consistent with your medication, because uncontrolled hypothyroidism long term, apart from making you feel not so great, right, in terms of gaining weight and feeling tired and so on, can also put you at risk for changes in terms of your cognition and your heart. In terms of, it can increase the risk for heart failure in a different way, in that it can cause you to lead to more fluid retention, putting a greater strain on the heart. Most patients that once they find their stable dose, they can live life as everyone else. I will have some patients that even once their dose appears stable, they don't necessarily always feel the best that they can. So quality of life for some patients will still be affected even once the dose appears to be adequate based off of the labs. So if that happens, then I might try to push the dose just a little bit more to get them to the lower end of what I think is acceptable for their TSH value. Right. So we usually, when we're monitoring, the replacement or the treatment of overactivity, we will use TSH to guide us to say, okay, how has the brain responded to this dose? Is it working well enough? And the labs, most of the common labs, reference ranges here locally, covers a really wider range of ages. So I will actually say that it says, for most of the labs, like 0.4 up to about 4.5. 4.5 for me is not necessarily acceptable for a young woman who's trying to get pregnant. So then I'm going to try and push it even further, the dose, to see if it can help to give them some relief in terms of their feelings and the symptoms, beg your pardon. And for overactive hyperthyroidism, depending on the cause, let's say if it is Graves', some people will go into remission. So I'll usually tell patients, anticipate to be on methimazole at least 18 to 24 months. So a year and a half to 2 years. And depending on how the dose is going, am I cutting the dose down? Depending on how your antibody levels are looking when I reassess them and they've come down, some people will come off of the medication. But At some point, most patients will re-flare and it will come back. For those patients with hyperthyroidism, more so from a European side, they are doing longer and longer term methimazole. But if you put it into perspective, let's say if I have a 19-year-old patient with hyperthyroidism, and we hope they're going to live to 80, 85, I don't ideally want them on methimazole because it has a greater risk of side effects compared to Synthroid or replacement hormone. So I'm going to recommend definitive therapy at some point. So definitive therapy for overactive thyroid, let's say you don't go into remission and it is Graves, then we consider radioactive iodine, as long as you don't have significant eye disease, because radioactive iodine can actually make that worse. Radioactive iodine, again, not available in country, but you can hop right over to Florida. It is a bit labor intensive in terms of isolating yourself afterwards for a couple of days, but it's something that patients do all the time. Or for some patients, especially let's say if you have multiple nodules in the thyroid and you're overactive, I would probably recommend you do surgery. Because even if we did radioactive iodine and we killed the overactivity, those nodules are still sitting there. We're still gonna have to watch them periodically. Sometimes we get to like once every 2 years ultrasounds. We're waiting for American Thyroid Association to come up with some new guidelines. Their current guidelines for thyroid nodules are 10 years old. So we're hoping this year, if not early next year, to get new guidelines. They claim that we should stop following the ultrasound at some point. But also for me as a person, as a physician, as an individual, I'd be nervous to completely stop, especially in a really young patient.
Yeah, because you want to know what's happening and how it's progressing. Or
is it progressing?
Right, you don't want to just leave it there.
Right. Exactly.
Right? Okay. This has been a great conversation. I think we've gotten through a pretty decent amount of information. I think our listeners have a lot that they can take away from this to understand how this whole process works, what they can expect, if they are seeing themselves having symptoms, things like that. If someone felt like they needed to come in and, get a further assessment, how do they go about reaching you? What does that process look like?
Excellent. So I'm over at our specialty clinic every day of the week except Wednesdays. And our specialty clinic is where the tiny shop used to be. The number there is 605-2030 or 2031, and they can always call to make an appointment. I can also say that there are instances, so for me as an endocrinologist, I apologize, I see way more hyperthyroidism as opposed to hypo. Hypo being more common, I feel a lot of my primary care colleagues have become comfortable with at least starting treatment. And it's only oftentimes that patients come to me if they can't find the right dose. Or I would also urge patients if they're having that concern, or if their dose just keeps going up and up and up and up. Sometimes it's an absorption issue, and it's not, they're not taking vitamins. I've diagnosed people with silent celiac disease because the dose was just way more than I would ever expect for someone of their size. But in any event, going back to your question, because I like to digress, you can call the specialty clinic and I'll be more than happy to see you. What I would suggest is if you're coming, bring any thyroid function tests you've had done, any imaging of your neck in terms of any thyroid ultrasound, CT scans that might at least give us a glimpse of the thyroid can be helpful. But if, let's say, you feel like you're hitting a wall in getting that assessed, I can start the process.
Awesome. I think we've had this conversation a couple of times with different guests on the podcast that the bringing whatever you have is always helpful, because as much information as you can give your physician in terms of providing them with a history, it gives you a much better starting point for being able to figure out, if something is going on and then what is going on. So that's always recommended and always helpful. Thank you so much, Dr. Cartwright.
Of course. Thank you again.
Always a pleasure having you on the show. Always really great information for our listeners, and we appreciate your time and your effort today.
Thank you so much. It's always a pleasure.
Awesome. So if this episode helped you in any way, share it with a friend. Be sure to subscribe on YouTube at Vital Voices 242. And be sure to reach out to Dr. Cartwright if you are interested in setting up an appointment at the specialty clinic, as she mentioned. And as always, we appreciate you tuning in each week for the nation's most vital conversations where insight meets impact. Until next time, stay informed, stay connected, stay well, and stay tuned for the next Vital Voice.
We'd like to thank today's sponsors, Oak Tree Medical Center and Wellspring Lifestyle Group.
Are you enjoying Vital Voices? Do you find our conversations educational, engaging, and inspiring? Then like, subscribe, and tap that notification bell to keep updated on new episodes and more.
Why you put this?